Woo.
I'm sorry. Hey, everybody. Good
Good
evening, and thank you very
evening.
much for joining us for another episode of Perspectives in Primary Care. I'm Dr. Dietrich, and I wanted to just give y'all a heads up. I don't know if you knew, but this is actually May, which is Older Americans Month. Did y'all know that? Maybe a lot of our listeners didn't know that. Well, indeed it is, right? And me, Dr. Dietrich, Dr. Carol Penn, and Dr. Khadijah Rapp, we're here with y'all tonight to discuss a necessary topic, a very necessary topic, and it's likely a sensitive topic for some of y'all out there. And just letting you know in advance, a couple of band-aids may get ripped off. You know what I mean? There might be a couple of ouch moments because you might have to come to some realization of a few things. But again, it's a very relevant issue. And we have a lot of Americans, here that are considered older adult. Now, as far as exactly what that cutoff age is to be considered an older adult, I actually feel that that can vary depending on like the physical condition, the mental condition,
Mhm, mhm.
as well as the calendar year. But you may have, some younger folks in the 30s who's got all kinds of aches and pains and getting around. They've had a hard life, making their life difficult to maneuver while you have a spry 70, 80-year-old doing marathons. You know what I mean? So definitely lifestyle and your mentation is definitely contributory. But in general, an older adult is, maybe 70s, 80s, but hey, maybe the 70s are the new 50s. You know what I mean? So I really believe that it's all in how you perceive it. You see what I mean? Older doesn't necessarily mean debilitated. It just means older in age. But having said that, for the purposes of this live stream, we're going to talk about our elderly citizens, okay, whose health may not be in the best of shape, and how we may have to have some difficult conversations and make some difficult decisions with them as well as loved ones, family members, and above all, we want to respect the wishes of our older ones. Okay. And this live stream actually stems off of suggestions that we had for show ideas. That one of the listeners, she has her mom who's older, and it was just very tough for her to see her kind of like declining in front of her eyes. She feels that she knows what's best for her, and the mom, she knows what's best for herself, but we got those two differences of opinions. You see what I mean? And so we want to help y'all kind of navigate through this and kind of have y'all know what to expect when you're going like to the ER or to the office, or even before you get to any of these settings in the home setting. Okay. So tonight's topic is we're going to be managing or talking about and managing the expectation and care of the elderly at home, in the ER, and if you go to the clinic, as well as if your loved one is placed in an inpatient setting. Dr. Carol, she's going to actually start us off by what needs to happen at home, those difficult conversations we need to have surrounding like end of life. Then Dr. Kadisha, she's our number one ER doctor. She's going to be talking about in the ER setting when you actually bring your loved ones in. Certain things will need to be discussed: HIPAA, power of attorney, advance directive, things that happen when a person is older in the ER, and you need to understand what things are possibly going on. And then me, I'll go ahead and bring it on in when you actually go to the clinic setting, or if by chance your loved one is going to need to be admitted into the hospital. What are some of the things that you'll have to expect or that you can find to expect? And so, again, we have Dr. Kadisha Rapp, our ER doctor, Dr. Carol Penn, our family practice doctor, and me, Dr. Dietrich, your family practice doctor. And I'm hoping, Dr. Carol, if we can see anybody chiming in first, but then Dr. Carol can go ahead and start us off.
All right. Well, good evening. I'm so
Yes.
happy to be doing another Perspectives in Primary Care with my colleagues, Dr. Dietrich and Dr. Khadijah. This is a subject when we talk about um, our older relatives and the older members of our society that is near and dear to my heart. As a child, I adored older people,
Yes.
and I definitely adored my grandparents. I was fortunate enough to know three of my four biological grandparents, one grandparent had died many, many years before I was born. She actually was my paternal grandmother. She died when my father was a boy. So, you know, it was long time gone. But everybody else I knew, including my step grandmothers, and I adored them. And fast forward in medical school, I actually did my research in medical school in hospice care and at the end of life. And I also, growing up, I had the privilege of watching the elders in my family have what I now would describe as very good deaths. And I believe that people have a couple of rights in this life. And I believe that people have a right to a great birth experience and they have a right to a great death experience.
Absolutely.
And we need to do better on both ends of the spectrum. And so, what I want to talk to you tonight is really about having what for many is a very difficult conversation, and that's planning for the end of life. And one of the things that I see now that I've, gone through medical school and gone through my research with hospice care and the end of life, I've done my rotations in hospice care, and I have certainly been a midwife to the death experience in the hospital setting and in the ambulatory setting as just a part of patient care, being a primary care doctor, a family practice specialist, if you will. And so often we don't have the conversation. And this is a conversation that I think you need to have in your dining room table, in the comfort of your own home with your loved ones, to have the conversation about how you feel about the end of life. One thing's for sure, the end of life is going to come to all of us. It is a visitor in all of our lives, absolutely 100%. And it can come at different stages in life, at many ages, right? So part of just having the conversation, what do you want for the end of life? It's appropriate to have at any time, but especially with our elders, because we know that if things go the way they go with human life, the end is going to come. And it is so much better for everyone to have it when people are reasonably well, when they're reasonably healthy, when there isn't a crisis. If you never have the conversation, then what we tend to see is what I call the calamity of death, as opposed to the grace, strength, and beauty and dignity of death that can and should happen at the end of life with just a little bit of planning, just a little bit of a conversation. So you can just start talking about, let's say it is your parents, for example, and they're getting on in years. Maybe there has been an illness. Maybe there is some signs of frailty, but no signs that, that anything imminent is happening. And that's when it's time, really, maybe, over a cup of tea, to say, gee, Mom, I know this is not going to happen. So, for example, anytime soon, and don't get me wrong, I'm not planning anything, but when you think about the end of your life, what are some of your wishes? What do you want me to know? What do you want me to do? And sometimes that can be a very gentle way of breaking the ice and getting the person, talking and laughing and saying, well, maybe they say, what, if I could really plan it, if I could really have my wishes, I might like to die at home. Or I want to make sure that I have my minister or my priest spend a lot of time with me and talk to me and visit me if it seems like I'm sick or it seems like the end is near. Oh, I want all my children to be here. Whatever it is for the person. And trust and believe, it is much easier to have this conversation when there's no crisis, when there's no imminent end of life that's about to occur. So I actually sit with my families and with my elder patients, and I ask them, as you know, and this is before we get to something more official like the advance directive. And I know Dr. Khadijah and Dr. Dietrich both will be bringing that up, but you might have heard a term called an advance directive. And in the advance directive, you can start to indicate some specific things like the DNR, or the do not resuscitate, or the do not feed, or the do not this, or the do not that. But before that, you want to know what the feelings are, because the thing that we want most to do when our loved one is making a transition is we want to honor them. And I know I can hear it with my patients. Dr. Khadijah and Dr. Dietrich have probably heard it with their patients' families. Oh, I know mama would have wanted that. I know that, daddy felt this way. And it's those feelings that become so important at the end of life. And the family member, I wonder if, mom would have agreed with this, and being sure about it versus questioning, should that be? And if there's siblings involved, again, having that conversation so you're not literally in the hospital at the bedside fighting over what's going to
Oh my,
happen next. I've
it
seen it.
happens.
And the
It
other two
happens.
ladies, we've seen it. We have seen it. Instead of being able to honor the loved one and be with the loved one and have your full attention on this moment, people actually fighting over whether the feeding tube should stay in or out. So I'm way, 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 way back over here away from this. And I'm inviting families to communicate. That's the number one thing. What are your wishes that you want to communicate around how you'd like to see the end of your life go? And if there's siblings involved, to have that discussion with the siblings, because the last thing you want to do is to be in the ER fighting, or at the hospital at the bedside fighting. And trust and believe, I have witnessed both, and it is not a good scene. Least of all, here's the person leaving this life and leaving this earth, and people are literally, missing this person's last moments. And this should be a sacred time for a family, a holy moment. And one of the things that we've seen that's been so stressful during this pandemic is people not being able to be with their loved ones as they were leaving this earth. And the sorrow of that, the strain of that, the upset of that. And that was something, that was forced because it wasn't safe for people to be in the hospital environment or in the nursing home environment when there was a lot of COVID-19 infection. So if anything, let's take a lesson from this pandemic and all of the death that we've had to bear witness to during this time, and just really recognize the need for human beings to be together at the end of life, to be there for each other, to be there for their loved one, and to have good, clear communication that simply begins with asking the question, what are your wishes? What do you want? What would be comforting to you when the end of life comes, as it is going to come to each and every
Everybody.
one of us? All of us will be visited by this. And then you can also, at the primary care visit, at the preventive care visit, or at the annual Medicare visit, that's the time, bring it up to the doctor. Or maybe, doctor, I think it's time to have this conversation with mom or dad, and I'm not quite sure how to go about it. So bring in your primary care doctor as a part of your team who can help you with certain parts of this conversation, and then begin to bring in the conversation about the advanced care directives, about healthcare proxy, about some of the more technical things that you will need to know as this is unfolding, as this is occurring. And a lot of people don't realize, you can call upon any one of us as your family care practitioner to help you with this. This is a very important part of what I call high quality healthcare and good quality health care. So we want to, and then, even bringing in the other siblings, we can have a family meeting. And these are all the things that I like to see done years in advance of the actual event itself, because trust and believe, it's so much easier to care for the patient and to work with the family who has had these preparatory conversations. And then there's a sense of, what the wishes are. And also, it helps me provide the best recommendations and care for the patient when that time comes. If I understand what the family's religious preferences are, what their spiritual preferences are, what their care preferences are for their loved one as their loved one is making the transition. So I'm going to say, communication, very important within the family itself, carving out that sacred time after a family meal, or just calling a special time over tea. Communicating with the primary care practitioner and making that person a part of the team if there's certain parts of the conversation that are more difficult. And then, or asking, and from this point, doc, I think I understand mommy's wishes, but what else do I need to know? And then bringing the family in so that when the time does come, these pieces are in place and there's a sense of love, a sense of community, a sense of harmony, and most of all, your loved one can feel supported and well taken care of at the end of life.
Absolutely, absolutely. I mean, that was well stated. What else can you say?
Well, there's a lot, because, there's the whole, the business of death and the moving through the hospital setting or in the emergency room setting. And I know that both, Dr. Khadijah is going to take us into some of these other aspects and some of the definitions. And then Dr. Dietrich is going to finish up the evening with us. So Dr. Khadijah, we are all ears. We're ready to learn from you.
Oh, thanks so much, Dr. Carol. And yeah, thank you so much for talking about how important it is to go over the end of life wishes and some of those documents too before coming to the emergency room. The first thing I must say is to take the unnecessary urgency out of an emergency. You prepare. Preparation is how you remove some of the unnecessary stress from an emergent medical situation. And because I've seen those family meetings happen at the bedside, happen as the person, is making their transition. And that's not what you want to have to do. Because even when you are prepared, there are going to be things that are unexpected. So why not ride those out a little bit better by preparing in a way that you could do starting tonight, with a phone call to your parents or your siblings to in order to get such a family meeting prepared, because some of these documents that you need to have in place, that you really want to have in place, should you end up at the ER for a critical situation, they need to be done by that person while they are mentally clear, while they are mentally competent to make those decisions to say, all right, I want my daughter, Sissy, to handle this. I want, Tom to handle that. Because you don't want people fighting over it again at the bedside. So
Dr.
So,
Khadijah,
yes,
ju-
ma'am.
along, just to add on what you were saying too, Dr. Carol too, don't be upset if your loved one brings it up before you bring it up. You know, if they
Mhm.
if they want to discuss it and get it out there, if we're talking about, we talk to them about having this meeting, but don't be upset and don't be in denial. Like Dr. Carol said, we all have to meet this appointment. If they bring it up, that they want to have the discussion, even if you don't want to hear, you have to respect them and just have the conversation. So I
Mhm.
just wanted to add that in there as well, because I mean, it's just a great point.
Right.
Very
Yeah.
good.
Allow your loved one to bring that up. And
Yeah.
I also wanted to say this is not just about the elderly.
Yes.
So Memorial Day weekend is coming up. A lot of people are going to be getting on motorcycles for the first time this year. And I have a friend who worked at a cemetery. And every week there was a funeral for someone who died in a motorcycle accident. So don't just
Mhm.
think this is about the elderly. It's across the ages. It could happen to anybody, young, old. I've seen them all in critical situations. So just as I'm going through the rest of what I'm discussing, so just want to go over those things. So they're like three legal documents that you need to keep in mind, take note of. So one is the HIPAA authorization form. That's the Health Insurance Portability and Accountability Act authorization form that allows family members or trusted family friends to be privy to the details regarding a loved one's health care information and medical status. Because if you come up there and we don't have any kind of written consent or permission for you to get that information, you're going to be pissed off when we tell you that we can't tell you anything. I'm sorry, pardon my French, but you're going to be like, yeah, but I've been coming by and taking her to the grocery store for 20 years. Yeah, but she didn't give you authorization to know what's going on. You're the only one she's got in this world. Well, she needs to, you guys need to go over that so that you are authorized to know what's going on. So that the first one is the HIPAA authorization form. The second one is the power of attorney, also known as the healthcare proxy document. This is a legal document that enables the main person to appoint a trusted relative or friend to handle specific healthcare decisions on their behalf. It does what the HIPAA authorization form does, plus grants the ability to make medical decisions for that person. And this is one that this must be prepared while that person is still mentally competent to give another person power over their care. So that's two, the HIPAA authorization and the power of attorney. The third one is the advanced healthcare directive. The Dr. Carol was talking about all of these, and this lets people record their wishes for end of life care before a medical crisis strikes. This living will can free a person's family from agonizing over difficult medical decisions, and it does so by providing instructions for the medical power of attorney to follow when making end of life decisions for care. And like Dr. Carol was saying, it can indicate what treatments the person does and does not want performed under certain circumstances, like CPR should their heart stop, being put on a ventilator should the person be unable to breathe on their own, or placement of the feeding tube like Dr. Carol was talking about. So just make note of those things. And yeah, thanks for coming, everybody. Dr. Zakia, Dr. Sylvia, Victoria, Kasali, DeJarvis, Jennifer, Hardette, Mom, thank you so much for coming in. So things that might bring an elderly person to the ER. Now, there are a number of things, and please put in the comments other things that I might leave out. I tried to go over the most common things. So one common thing is just not eating. And there are a number of reasons why an elderly person may stop eating. And I'll admit, at one point I thought just not eating was a normal part of aging, but it's not. It's not a normal part of aging. There are different things that can cause this. Maybe things that you can head off at the pass, to keep your loved one out of the ER for this reason. So painful, poorly fitting dentures, tooth decay, loneliness, depression, those things can cause someone to stop eating. Side effects from prescription medications, decreased physical activity, and constipation. You will not believe how often constipation drives people to the emergency room of all ages. I had to treat a little one, a 1-year-old, for constipation just yesterday. Dementia, it might make someone forget how to eat or chew. Dehydration, infections, things like that. So when folks come in for, not eating, what we're going to do is we're going to look for more serious things. Elderly people might have atypical or subtle or vague presentations for very serious conditions. And you think that, mama's not eating. Why are you sticking her? What you need to get blood for? There might be an electrolyte imbalance. It might be dehydration that could be manifested by kidney failure or decreased renal function that we will see just on a basic metabolic panel. It's one of the simplest blood tests we get. We're going to check for everything, especially, and you might think that it's a lot, but sometimes a heart attack can have a simple, vague presentation, just decreased activity. Could be that, especially if they have diabetes. So we're going to check for everything. Failure to thrive. You might hear that term being thrown around. You might overhear doctors talking about your loved one, while we're trying to get someone admitted. And that's a state of decline that is indicated by weight loss, decreased appetite, poor nutrition, inactivity, and we're going to look for causes of that too, because often I end up getting in fights with the hospitalists. Those are the people who admit people to the hospital, and they'll tell me failure to thrive is not an indication for admission. You're going to have to find something else, ER doc. And so, that means another hour stay in the ER while I'm looking for a reason to get your loved one admitted. So we're going to look for dehydration, which could be manifested by kidney failure or decreased kidney function. Maybe acute flares of chronic disease. Say if they have like congestive heart failure or something like that, that could cause some weakness, decreased activity. We're going to look for reasons to admit your loved one, because elderly folks are more complicated and they typically have a higher tolerance for pain and a higher threshold for complaining, a higher threshold just for talking in general. So we're going to look for everything, and because we want to make sure that your loved one gets fully evaluated before sending them home. So dehydration, another reason why your loved one might end up in the emergency department. And I want you to remember 3 things, the 3 Ds of dehydration: diarrhea, diabetes, diuretics. All those things can cause you to lose fluid. And even naturally, as we age, the body loses fluid. You can see in your face, like the volume loss, like around the eyes and things like that. Like you can even see it there, the loss of fluid and volume that we have as we age. And dehydration can lead to a number of things. In addition to kidney failure, it can lead to loss of consciousness, decreased mental status, low blood pressure, falls. And so don't be surprised if you bring your loved one into the ER for a fall and we tell you, oh yeah, they're dehydrated, they're not drinking enough. Mm-hmm. And that can happen sometimes because the elderly are less, they don't react as keenly, or they don't experience thirst as keenly as young people do. So they may go longer without drinking as much as they need to. So you have to watch their fluid intake to avoid, because that could be the difference between them ending up in the hospital for a few days and being able to stay home. UTIs, urinary tract infections, due to poor fluid intake. UTIs and dehydration often go hand in hand. in the ER. Poor fluid intake, hate to say it, but poor genital hygiene, poor urinary hygiene.
Mhm.
And that's another talk in itself. But, like wiping front to back is the right way. Wipe front to back. Change those Depends a little more frequently. Change those diapers a little more frequently, things like that. If your dad has an enlarged prostate, that enlarged prostate could cause a blockage of that will decrease proper emptying of the bladder, which can lead to urine just hanging out in the bladder, causing a UTI. And they might, your loved one might evidence that by, going to the bathroom a lot, urgency, complaining of pain, lower abdominal pain, or incontinence. Sometimes confusion, but confusion usually is not the only sign that you'll see with a UTI. Look for other reasons if someone just suddenly becomes confused, like a stroke.
Yeah.
Strokes can be manifested by confusion, focal weakness, the weakness of one arm versus the other, facial droop, trouble seeing in one or both eyes, sudden trouble walking, dizziness, sudden headache without a known cause, especially if someone has uncontrolled high blood pressure. So if someone does have high blood pressure, check their blood pressures periodically at home so you can see what they are, because often if they end up in the ER, their blood pressure might register higher than it would at home. So it'd be good if you knew what their blood pressure normally was at home. Another thing, the thing that we always check for, almost no matter what anyone comes in for, we're checking for heart attacks. That's another reason. Typical signs: chest pain, shortness of breath. It could be, neck, shoulder, arm pain. But the elderly can have other symptoms like abdominal pain. If they have diabetes, they could have, all bets are off. You could have a number of vague, subtle symptoms for a heart attack. So we're going to check for that. And then Dr. Dietrich had advised that I mentioned a couple of days ago, bowel obstruction. If someone's had surgery at any time in their life, on abdominal surgery at any time in their life, they are at risk for a small bowel obstruction. Anytime a surgeon opens the abdominal cavity and they put their hands on our intestines, at any time in life, our intestines could get a little sticky and close. That open tube could close, and grandma's belly suddenly looks like a beach ball. It's just, and she's not eating, she's not passing stool, she's vomiting everything that you try to give her to eat. And it could be that, ask yourself, did grandmother have a surgery? It could have been the C-section that gave birth to you 45 years ago. That could still be causing her belly to look like a beach ball at 80 years old. So, so those are some of the more common things. I hope people put in the comments other things that they had to go to the ER for, with their loved one. And doctors, if you want to add anything. Did I cover just about everything, Dr. Dietrich, Dr. Carol?
I think you got it. You got it.
Okay.
Yeah. I learned a lot too. Yes.
So it's just good so going back to those 3 legal documents, I've had families come in with their relative who, may be at the end of life. And I saw the difference between the family having the first family meeting in 20 years at the bedside versus the ones that tell us, hey, mom doesn't want to be on a ventilator. She wants to go peacefully. She doesn't want y'all poking and prodding and sticking tubes in her. She just wants to go peacefully, untouched. And we know that, and we let them go, with more dignity. So it'd be really great if you could get those legal documents together: the power of attorney, the HIPAA authorization form, and the advanced healthcare directives, also known as the living will. So with that, I'm going to pass off to Dr. Dietrich.
Good.
And I can't hear what happens after they leave the emergency room.
Yes, but I just wanted to say too, if you think about it, it's really a gift. If you can provide your loved ones with what to do when you're no longer able to make your own decisions, or if you know if you do pass, it's really a gift to them. More of a peace of mind kind of thing for them as well, so they can continue with their lives and whatnot, and not have to worry about if they did the right thing, or did I do everything I knew how to do, and that kind of thing. So I think it's very, very important to start having those difficult conversations. You just have to. So okay, so I'll just transition a little bit. So, even if it is like an ER follow up, or you're just coming into the clinic because you have a concern, you bringing your loved one in. I'm not talking about just like a well adult check where you're seeing how they're doing. Seeing if their medications are okay, you're refilling their medications and they're out the door. But this is a visit if like the child or the caregiver brings in like an elderly parent, or who they're taking care of, and with their multiple comorbid issues, and they're just declining, and they don't look good, and they don't know what to do, and they're just getting weaker, and they're not wanting to eat. And so there's definitely some things you can do before you even get to this visit, and it's all in preparation too before you come to your outpatient visit. So I'm going to talk about the outpatient visit, like if you come to the clinic, and then what to expect if your loved one is actually admitted either from the ER or a direct admit from the clinic. So a few things to consider. You want to bring all of their medications. An alteration in their condition could be because of polypharmacy. Okay, a lot of older people are on multiple medications, and that's what polypharmacy is. And a new medication might have been started. Medication changes, and that can actually change a person. Like Dr. Khadijah was saying, a diuretic. Suppose the diuretic dose was increased, because they have heart failure. The person becomes dehydrated, and so you can see them decline in that way. So bringing their medication is a big one, or at least a very complete, up to date, like you just did it before you got there, list of their current medication and their doses, including over the counter supplements. I have many patients, and I know all y'all do have patients who take over the counter supplements that they don't consider a prescribed medicine, but it is still something that's entering their body and still altering their physiology, and it can make a difference. So bringing all of those things there. In the visit as well, you want to ask questions about their conditions. If you have to bring a list, that's fine, but write the answers down, because a lot of things that are discussed you may not remember in the visit, including the prognosis. You know what I mean? So you may have to even share this with the other people who aren't allowed to come into that visit, because in this day of COVID, we're not letting everybody just come into the office right now. We typically say either the patient alone or their caregiver if they have to have them. So having that there, and I've even like talked on the phone to a caregiver who's on the phone if they can't physically be there. But yeah, take those notes, okay? Um, if you have an advance directive like was previously taught about, bring it up. Even if you have a copy, we could put it as a part of their medical record. You see what I mean? So that would be even a DNR. That would be a great piece of information to have in case you do have those times where there's not a lot of certainty, or if your loved one comes by themselves and they don't know. Bring readings of blood pressures and blood sugars. That's very important, because differences in their blood pressures and blood sugars can definitely have an effect on a person. If they're checking their own blood sugars and blood pressures, if they're running too low, that could definitely cause changes. If it's running too high, that could definitely cause changes. And then that can start a conversation if the medications or whatnot need to be tweaked. So it's not always the end of life. It could be something as simple as medications. I also mentioned too, in preparation for the visit, don't be upset if your loved one brings up end of life. Suppose there is a terminal, diagnosis, or a condition that they're just eventually going to deteriorate. Don't be upset if that conversation is brought up. What I like to do in my visits as well, especially in these types of situations, is I outright ask if they haven't been to the ER, if they've been at home and they're declining. I'll ask them, is there anyone who's there to make decisions on your behalf if you're not able to? Do you have this in writing? And they'll either say no, and I say, well, I'm not saying anything is getting ready to happen now, but I think this is a great time for you to start preparing and thinking about it. Okay. And so they're like, oh, okay. And then I also say to the child too, you too, just because you're younger don't mean nothing can happen. You know what I mean? You need to have something on the books as well. And so that kind of like brings things home for them. Okay.
Mhm.
So in the outpatient is where a lot of education can take place. We don't always have the full time to do it, but a lot of education can take place, answers to some questions that can be answered, and just knowing what to expect about a person's condition and getting more educated can actually alleviate a lot of stress and can actually make the person and the loved ones understand, okay, this is what is happening with this particular condition, instead of coming in saying, oh, why isn't this going on, why aren't you doing this. You have to understand that some disease processes have courses. All right. And if you could just be more educated, it'll just make things better all around. Okay. And I'm going to talk to you about just right now how Dr. Khadijah touched on, as a person gets older, some things start to happen with the body. It's just how it is. And if you can understand that and better, you'll be better prepared to know what happens. We talked about drinking. Sometimes elderly people don't want to drink a lot. And then on top of that, if they have, conditions where they're on a diuretic, that's going to make them even more thirsty and they may not even realize it. A person with Alzheimer's, sometimes they don't want to eat. They don't want to drink it. So that can really, you know, cause a lot of stress and distress for caregivers and family members. Actually, as a person gets older, the ability to taste and smell actually starts to diminish a little bit. This is a part of aging. Taste buds are a little bit less sensitive. Um, the skin gets a little bit thinner. Okay, so you may see elderly people when you see their veins more. You might see skin tears. It might not always be elder abuse, which that is definitely another topic for discussion. But their skin is just more fragile. All right, the hearing can decrease. Nerves in the body that can actually conduct signals a little bit more slowly. Blood vessels become what's called less compliant. They become a little bit more stiffer. um, our overall muscle mass becomes a little bit weaker. Okay, if a person isn't actively like lifting weights, exercising, and whatnot, just those muscles just start to deteriorate. Um, the muscles that you use for breathing, called the diaphragm, actually becomes a little bit weaker too. All right. And then the overall digestive system is not as much affected, but it definitely is affected. So, like Dr. Kadisha said, constipation is a big one. Things are just moving through the bowels a little bit more slowly. And, if you have like a bowel obstruction, if you have some adhesions, all that plays into effect. So, knowing some of these things as a person normally ages, if you can educate yourself to that, you'll kind of be prepared what to expect, not only for your loved ones, but for yourself. Of course, those joints wear down, that arthritis kicks in, that happens a lot. Um, these are just a few things that I'm mentioning. There's quite a few more. We can do another live stream about that. But just being educated can alleviate a lot of anxiety with the family. Okay, so a couple of things. When you're in the office visit with your loved ones, you want to give them dignity, even if they can't get their words together, even if they do have Alzheimer's, even if they have mental decline, you want to let them speak. All right. It may be the tendency to talk over them or talk for them, but give them that dignity. Whatever they need to say, just let them, mention it. All right. Now, we're in the visit and we decide that they're not doing very well and it does warrant an admission, all right, to the hospital. So you can either become admitted from the ER or you can be admitted like in the clinic, and it's called a direct admission. All right. Keep in mind, though, before you even get to the hospital, though, or get to the floor, in this day of COVID, admitting to the hospital, they probably won't let you go in there with them unless you're like a direct caregiver, and someone just has to be there, not just if you're just the daughter who wants to be by the side. More than likely, they won't let you. But basically, find out what the policies are for your particular facility. All right, and as things are starting to open back up, they may become a little bit more laxed on that stuff, but maybe not. So just be prepared for that. So if that's the case, make sure your loved one has like their cell phone charger, so they can be able to communicate with you. So a few things are going to happen when the person gets into the hospital. There's going to be a lot of questions, a general intake by the nurse. They're going to ask you, is there an advance directive? Is there a DNR? You know, again, when I come to see you, again, I'll say, I'm not anticipating anything that's going to possibly happen now, but if you don't have one, y'all really need to start thinking about it. All right. Consults are going to be done. Whatever specialist is needed, it is deemed by your admitting physician. If you need to be seen by a cardiologist, you know, for the heart, you know, for the kidneys, nephrologist, you know, specialists are going to be consulted to help co-manage your loved ones. Blood work is going to be done. Urine is going to be done. Even if it was done in ER, it might need to be repeated the next day to see if there's any changes, right? Imaging might be done for the same reason. We need to see if there's anything that's progressing, getting worse, or actually getting better. So additional imaging that wasn't done in the ER might be done, or just follow-up imaging. Social services are going to be consulted, okay? And this is for not only for discharge planning, but to see if there's any needs that need to be met while you're in the hospital, all right? If you need any medication assistance, that kind of thing. Where you're going to go afterwards. Nutritional evaluation, nutritional services. So there's actually a dietitian that's looking at your chart, reviewing your labs, and seeing what from their perspective, what they can do to help optimize your nutrition. All right. Possible physical therapy. If someone is coming in and they're weak, they're not getting around pretty much, and we're anticipating a longer stay, you know, we may have to have somebody come with you to the bedside to help get things moving, to help get you a little bit stronger. Clergy. Okay, clergy. There may even be a consideration for artificial nutrition. So I'm not going to go over all the different, you know, issues that can bring a person into a hospital, because there's definitely many. But just keep in mind those basic things are going to be done, and you need to have this discussion with your doctor. Then ask questions. Ask, you know, why is this being done? Of course, in a respectful way, but you know, what's going on? You know, what does mama have? You know, what can I expect? Okay, so of course these are all generalizations. So the hospital stay is done, and there's basically, you know, one of three things are going to happen. One is that they actually improve, you know, or they're stable enough to be discharged to home in their normal, regular surroundings. The second one is they actually don't improve and they succumb to their illness. All right. And the third thing is that they'll need additional or further or different care that can't necessarily be done in the inpatient hospital setting. Okay. So one of those things is hospice care. A person is, okay, so sorry, back up. Hospice is a concept or a special kind of care that happens. And this basically focuses on a person who has been deemed that their life expectancy is going to be less than 6 months. Okay, they have a life-limiting illness, and it provides compassionate care for people in the last phases of an incurable disease, so they can live comfortably and as fully as possible. And it doesn't mean that you just give them pain medicine and nothing else, and you don't do anything else for them. It's not that. It's kind of a whole bunch of different things that go into it. And like I said, it doesn't treat the terminal illness. And hospice doesn't mean that you're just there waiting to die. It doesn't mean you've given up on life. It doesn't mean that. We want to make this person as comfortable and with having enough dignity that they can at the end of their life. Okay. Another thing that can happen upon discharge is they can go to what's called a swing bed. And say a person is stable, but there's not going to be any different management in the acute hospital setting, but they're not good enough to go home. So this person would be a candidate for like swing bed. So like if a person had a stroke and they're doing great, you know, physiologically, but they just need more exercises, more strengthening exercises, or if a person has had like a knee replacement or a hip fracture and they're stable, but they just need to get more stronger, then swing bed is that option. All right. Home health care. And this is basically a wide range of healthcare services delivered at home by a licensed medical professional. It's not as expensive as being, you know, in the inpatient setting, and many services are offered, such as therapy, checking vitals, wound care, blood sugar monitoring, just a whole constellation of things. And this is what will be discussed when it's getting close for you to be discharged. Okay. And then there's a long-term care facility, and this is 24/7 care. The person is fed there, meals are given, medications are given, physical therapy, there's activities and all that stuff that can kind of take care of the whole person and deal with their issues. And a physician does come and treat the person there. Please keep in mind these are all options other than going, home on your own, and you need to meet certain criteria to go into these, different facilities, and that's usually dictated by insurance, unless it's private pay. And so that's definitely something you'll have to discuss with the discharge planner. All right. I know all these things that we've talked about can really weigh heavy on your heart, but it's just a topic that just needs to be, discussed. Coming from a personal standpoint, I lost both my mother and my father, and they had the foresight a long, long time ago to have all of their arrangements made. And from the burial, they had the will, they had, power of attorney and everything. And of course, losing them is the worst thing ever, but there is that peace of mind and there was that direction. And she's always brought up to us what mom always brought up to us what she wanted. And so we had a clear understanding of what was to take place. And it was like the best parting gift she could have, ever gave us, and dad too. So just keep that in mind. If your loved one brings it up, it may be a difficult pill to swallow, but you need to swallow it and get on the same page. Everybody does. In closing, when you're with a person who is going towards their end of life, sometimes it can get a little bit sad. It can get frustrating. But all I have to say is cherish the good days and the bad days. There may be more bad days than good, but still love them and still cherish them, because you'll never get it again. And please respect their wishes if you don't agree with them. Suppose they say, I want to be cremated, and you're like, no, I don't want you to be cremated. I want you to be buried. It's not up to you. Just like you don't want someone telling you how you want your life to be, respect their wishes. It might be, again, a hard pill to swallow, but we have to do it. And then have them in on the discussion. All right. So those are just some of the things that we wanted to share with y'all, because, people are getting older, they're staying older longer, but that means that there's more issues that may need to be addressed. And so it's great if we can all be on the same page on what our expectations are and theirs when it comes towards the end of their life. And then I guess, does anyone else have anything to add to that?
Well, that was excellent.
Yeah.
That was excellent.
Yeah, it can be kind of sad, but I mean, it's necessary. I mean, like we always say, nobody can reschedule that appointment. When it's your time, it's your time. And it's just to be prepared.
That's true. My parents gave me that gift as well as what you were talking about with your parents, so that it was difficult enough as it was when my father's end of life came, but to not have to deal with the burial, the will, all of those things were done and taken care of. So I could do what I needed to do as a daughter. And at that time, it was to grieve this man whom I so deeply loved. And I didn't have, all of that other stuff with question marks. So it was truly a gift that my parents have given me, just as your parents gave that gift to you, so you and your siblings at the time of their transition could do what you needed to do, which at that time it is to grieve them.
Yeah.
Yeah, and my grandmother was very clear about what she wanted her how she wanted her final wishes to be carried out. It made it very easy. It was seamless, and like I was saying before, just dealing with losing a loved one is hard enough, but she took care of the unnecessary worry and agony of trying to figure out what she wanted. She told me down to the color of her dress and her gloves what she wanted, and it made it very easy. And I know my mother and I have we've been working on our advanced directives and power of attorney also. So
Okay.
Yes.
Excellent. Excellent. Well, thank you very much, ladies, for another great episode.
Yes.
Please, you all who are watching, if you're watching on the replay, put hashtag replay. Put any suggestions you all may have for future episodes of Perspectives in Primary Care. So I'm Dr. Dietrich Gorman. I am your board certified family practice physician. I am a speaker, a best-selling author, a podcaster, a blogger, and I'm also known as America's Relaxation Doctor. And I help individuals who are stressed at work learn to relax and refocus in order to have a more healthy, productive, and fulfilled life. Please check me out on my website, drdietrichg.com, DRDEITRICKG.com. You can also purchase my book and my coloring book on this website.
Mhm.
Also, follow me on all social media. Thank you.
All
Sure.
right.
Dr. Khadijah?
So, hey, everybody, I'm Dr. Khadijah, your board certified emergency medicine physician and sports medicine fellow. I'm a speaker, best-selling author, consultant, concierge physician, author of the book, Help Us Help You in the Emergency Room. It's what an ER doctor would tell you if she only had the time.
Yes.
And creator of the mobile MD kit, which should also help you stay out of the ER, for minor illnesses and injuries. So my kit, my book, and my blogs help people feel better, be safer, and better prepared for emergent medical situations. Do follow me on Instagram at dr_Khadijah_MD, and follow me on Facebook at dr_Khadijah_MD, and check out my website, which is the same, drkadishamd.com, where you can check out the book and the kit and the blogs and more information about me. Thank you. And Dr. Carol, last but not least.
Hey, well, I am yours truly, Dr. Carol Penn, doubly board certified in family medicine and obesity medicine. I am also a master movement meditation and mindset coach, 2-time best-selling author. My book, Meditation in a Time of Madness, a guidebook for talented tweens, teens, their parents, and guardians who need to thrive, debuted at #1 in Amazon in February 2019. I'll never forget it. And I'm also a sought after speaker, podcaster, blogger, and I love my small group coaching program as well as my one-on-one coaching program, where I help you walk in your purpose and transform your life and be the change you want to be in the world.
Excellent. Well, thank you, ladies, and we will see y'all soon.
All right. See
Thanks,
you again.
everybody.
Good night,
Bye.
everyone.
Thanks for watching.
Good
Okay,
night.
bye.